Welcome to today's session, sponsored and put on by the East Texas Geriatric Education Center, addressing difficult topics in aging and disease. This is session 3 that will focus on everything you need to know about cancer. I would like to acknowledge our partnership with the East Texas Area Health Education Center East that have been really valuable in terms of our collaboration and distribution and connections with our consortium partners in East Texas. Okay. This is, as I said, the third session. It's in a series of 4 dealing with these difficult topics. And when you want to look at it, it is really about challenges to working with older patients and disease processes. And we will have our final session on the third Wednesday in May 16th, looking at modeling long-term care that will focus on nursing home residents and older prisoners. And we hope you can make it then as well. This will be a very short introduction because we have a lot to do today and a lot to fit in 3 hours. And everything is in your handouts, so I'll just briefly go over this so we can get going here. You have your agenda here with our 5 speakers, and this will cover the whole gamut of cancer care with an overview of basically epidemiology, cancer given by Catherine Coaxley, then looking at screening with Dr. James Goodwin, treatment of cancer with Dr. Holly Holmes, a short break, and then to kind of go along with treatment, what about overtreatment or aggressive treatment? And this will be given by Dr. Gulshan Sharma. And finally, with Dr. Linda Elting, supportive care, not just for treatment for end-of-life care, but this new wonderful area of survival of cancer. Okay. And this will also be set up now as a webinar, and I will give you later on, those that are connecting as a webinar, the number to call in for questions and answers. Okay. The whole day has a list of learning objectives, which are listed here and in your handout. And we teleconference to our 5 of our consortium partners in Lamar, University in Beaumont, Stephen F. Austin in Nacogdoches, Baylor University in Waco, Victoria College in Victoria, and Weatherford College in Decatur. Okay, there's lots of information available for CME. These are all free credits for doctors, nurse practitioners, and physician assistants. I need to disclose that all except Dr. Linda Elting have no commercial financial interests or affiliations to disclose. Dr. Elting discloses the following relevant financial relationship with Helsinn Pharmaceuticals in terms of having grant and research support. And the same for nursing with CNE, similar disclosures, and all the paperwork evaluation forms are in the back. Okay. Physical therapists, we have CEUs available as well as for occupational therapists. This is really about CERSIT, Comparative Effectiveness Research in Cancer in Texas, and all the speakers are affiliated with CERSIT. And you can find out more about this work being done, this collaborative work, which has been wonderful because we've been bringing in other researchers from MD Anderson, Rice University, University of Texas School of Public Health, and Baylor College of Medicine, and the Texas Cancer Registry.
Tony, thanks for the invitation. Now, I have to give 2 disclosures. The first one is I'm a pulmonary critical care, and I do provide aggressive care. So that is my role. The second is, I think both Holly and Jim left. I think the trouble is I have to provide that because they stopped taking those slides to their patients. If they show those slides to those patients, then I may not have to do this job for them. So this is pretty much my talk, and I'm going to go ahead and here are some of the objectives. There are quite a few slides there, and I think because we are running over a little bit behind, so I'm going to try to make sure that we meet, and Linda has her time to cover the important topic at the end. So here are my objectives. We're going to recognize variation in end-of-life care. Even though the talk is mostly for cancer, it is applicable to cancer, but I'm going to cover broadly end-of-life care. And I'm going to provide some examples in terms of aggressive care during end of life. and examine the factors which are associated with inappropriate end-of-life care and discuss some ethical dilemma. Now, this is Art of Dying in 2011, so we can say this is Art of Dying in 2012. This is a typical patient in an ICU setting, dying of multiple comorbidities and of age. And this is a real patient. Now, one other thing at pulmonary critical care, we don't shy away taking real picture of our patient, unless Holly, who took picture from Google, or Map. This is Mac. This is the patient I took care in September 14th, 2011. This picture was taken with permission from his wife. Mac's story is he is one of few World War II veterans who were still alive in Galveston. There are only a handful of them. And he was 93-year-old when he came to the ICU. He was admitted under cardiology services first because of, quote, congestive heart failure. They thought he had some pleural thickening. And he has this recurrent hypoglycemia issue, the whole issue of frailty and some decreased nutrition. And he was transferred to our services in MICU because of respiratory failure. And he needed non-invasive ventilation. One of the beautiful things about this is he really enjoyed his life. He loved fishing. He had good buddies where he goes and fishing pretty much every day. And he has a very dedicated wife who's been taking care of him for many years and has been fairly functional even for his age. But he has been coming to the hospital fairly frequently over the last 6 months. And this time he was in the ICU. And right now I can tell you, his eyes are open. He does not know what is going on. He is unresponsive. And I'll tell more about his story later. So think about Mac as we go through this. So if you talk about end-of-life care, 6% of Medicare beneficiaries who die each year consume 30% of Medicare expenditure. If you get a chance, watch this CBS 60 Minutes live on end-of-life care, which was presented in August 7th, 2010. Very nice clip, about 15 minutes, where they interviewed Elliot Gregg from Dartmouth Atlas Group, and also a critical care physician on that, talking about state of end-of-life care in the U.S. And Medicare do spend pretty substantial amount of money in providing care in the last 2 months of life, and it is estimated at least a third of it is overuse care. Now, you would always argue, what is overuse? So it does turn out that there is actually a definition by Peter Orszag, who was actually the prior director. And he said overuse occurs when a service is provided even though its risk of harm exceeds its likely benefit. That is, when it is not warranted on medical grounds. So this is pretty much considered as overuse care. And you can take some of the example from Dr. Goodwin's talk about screening. Is screening in patient 80-year-old is overuse of care? So then the next thing, which was very fascinating about this whole a testimony that Peter Orszag gave to the Congress, was how can care at best medical center in the world cost twice as much as care at the best medical center in the world? So think about it. Why is the care at two of the best medical care center are different? So why couldn't be that the care which is provided at different centers should be same? So I'm going to share some of the data. Now, a lot of the end-of-life care, if you think about it, is almost resurrecting the dead. So what you do is you have dead people, you see the care they received in the last 6 months. So that is how you're resurrecting the dead. You're picking them up. You are trying to create a story, what kind of care they received. Some of them you go back up to 30 days. Some you go up to 6 months before their death. Some you go all the way up to 1 year. And people have concerns regarding that. Is that really a right way of studying death, or you should follow these patients prospectively? It turns out whether you're resurrecting the dead or following the alive until they're dead, the data is pretty similar. So there is not much of a difference in terms of what end-of-life care data shows. So this is what Peter Orszag meant. This was a study that was published in BMJ in 2004 by John Venenberg. What he showed was he took 77 top U.S. hospitals based on U.S. News and Report, and he studied the care that the patient received in the last 6 months of their life, and showed this is, if the care is same across all U.S. hospitals, it would be 1. So you can see large variation in best U.S. hospital. It is over 2-fold differences in terms of number of days spent in the ICU, number of physician visits, person admitted to the hospice. This is considered to be appropriate care. and percent of death in the hospital. So this was one of the major findings that came out of this study, that there is large variation in end-of-life care across best U.S. hospital. We are not talking about any hospital. These are reported in U.S. news and report. Now let's talk about here. This is the latest data we have from, you can go to dartmouthatlas.org. You can pull what kind of end-of-life care we received here in state of Texas. And I just picked up few hospitals closer to us, UTMB, Methodist, MD Anderson. So this is basically the end-of-life care for Medicare beneficiary. You can see the number of days they spend in the hospital, number of ICU days is pretty high in Clear Lake Regional compared to UTMB. Looking at number of percent deaths in the ICU, pretty high in Memorial Hermann compared to UTMB. And if you look at percent dissident enrolled in hospice, very low in McAllen, Texas. And you've already read a New Yorker editorial about care and cost of care of Medicare beneficiary in McAllen, Texas. It is almost 2 to 3-fold higher than any other county in Texas, even you look at the same ethnic distribution. So the question always comes, well, your condition is serious, but you can take some comfort in the fact that nobody lives forever. So that's basically the whole story about this thing. Is now, what are the indicators of aggressive care? These are some of those indicators. ICU use, some say during last 6 months of life, some say during last 1 month of life. In hospital, CPR, okay? It's overrated, okay? And I'm going to just share some data for you there. Intensive use of chemotherapy, ER visits, hospitalization, and low rates of hospice. High rates of hospice would be appropriate care in some of these cases. Now, what do we know about ICU care? Now, ICU is a wonderful place, okay? It is very good if you are young, if you have treatable condition, and if something is reversible. It's a great place. And it is good for monitoring. It is good to provide mechanical ventilation, vasopressor support, cardiopulmonary resuscitation. Most ICU in the country do provide this care. And overall, the quality of care has improved tremendously, even for coronary care units. That's how original ICUs were started, then the trauma care. So the outcomes have remarkably improved. But it turned out people's trying to start getting benefits of things where there is no real data that it really helped in those cases. Now, what is overall ICU use in US? This was the data we have from hospital file data from patients discharged from 6 different states. So what they showed that at least 1 in 5 Americans either are going to have used ICU or died during the ICU or died after using the ICU. So about 20 to 25% of the US population will be using ICU care towards end of life. So that's the data that we know. So what happens to older adults who survived their ICU stay? So now there's always this example, there's a 77-year-old, came in with pneumonia, you intubated them, gave antibiotics, took care of them in the ICU, and all of a sudden, patient got extubated. Now the patient got discharged to the floor, 2-3 days into the floor, then what happened? So here is a nice data to showing that cumulative survival and those who were mechanically ventilated. So those who were mechanically ventilated actually had a much lower survival down the road. This study was followed up to 3 years. This was Medicare beneficiary, those who were hospitalized. These are not cancer patients in general. These are all Medicare beneficiaries who were hospitalized and had an ICU stay. It turns out at least half of them are dead by the end of 3 years, those who received mechanical ventilation. So this is our data here. We were trying to also look at vasopressor. Vasopressor, what we use for is to increase the blood pressure when somebody is hypotensive and do not respond to fluid. We were trying to see is what usually happens is people get epinephrine, norepinephrine, dopamine, dobutamine, vasopressin. The idea is when do you stop? And the key is 1 good enough, then 2 or 3 or 4 or 5. So we looked at our own data. It seems like if you are using 3 or more vasopressor, very less likely chance that the patient is going to survive that. So once you have maximized on Levophed, adding epi, additional dopamine is not going to make a difference unless the patient is getting something that is treatable. So the only patient who actually got either a cardiac transplant or an LVAD or had a PCI, they are the only one who survived. So multiple use of vasopressor in ICU is also an aggressive care without any real benefit of outcome. Now let's talk about CPR. All of you have seen the New England Journal article that was published almost 2 decades ago where they showed survival of in-hospital CPR in episodes, TV episodes. Have you seen those ones? So what do you think is the survival of, if you look at all the codes that happened during TV show, ER, whatever MASH, whatever the popular show were, what was the survival rate in those episodes of CPR? It was actually 70%. So there was 70% survival of CPR in those episodes. But if you look at what the data showed, this was the largest study looking at Medicare beneficiary who actually received in-hospital CPR. Only about 1 in 5, 18% do survive to hospital discharge. And survival was lower in African-American. This was more of a, and if you look at, regardless of survival, if you look at the data over 20 years, there is no change. So the in-hospital CPR, there has not been any change in outcomes in 20 years. The survival of in-hospital CPR is the same in 1990s, it is same today. It's probably one of the only fancy thing the medicine doc do is, in hospital, doing CPR as a resident. That's the fun thing. The surgeons do a lot more fun. They open the chest, they do the surgery. For medicine, CPR is considered that, how many codes you attended and whether you have really good experience. And my another issue with that is now we have rapid response team. People are not that experienced in doing good quality CPR. Even though everybody else have this ACLS certification that they all have to go every 2 years, simulation is very different than real life. Real life, you don't even know where the chest is and how you press on it. On a dummy, you can do very good, to get your stuff. So that's another thing with that. This is basically another thing which is interesting is those who survived, majority are actually going into skilled nursing facility. They're not going home. So in general, for in-hospital CPR, the outcomes is very lousy. Now, so this is basically the summary of what I just said. Now, what about CPR in ICU? This goes back to same patient of Jim and Holly didn't talk to them and showed them the data. They decided to get chemotherapy. Now they got side effect from chemotherapy. They're intubated in the ICU. Now we are having the discussion with the family. Hey, what if the heart stopped? Do you want a CPR? What if, there's always this checklist that people have made. To me, you either get everything, you didn't get anything. But people have this checklist of intubation, CPR, defibrillation, vasopressor, blood products, antibiotics, fluids. That's like a 7-thing list in the code status that you have to address. So this is the National Registry of CPR, basically showing the outcomes of patients who underwent CPR while in the ICU. It turns out only less than 4% are discharged home, those who got in-hospital CPR. So if you're a real cost-effective, somebody did a cost-effective analysis on in-hospital CPR. So for every 1 quality-adjusted life year, what do you think is the cost of in-hospital CPR?
Just only elective CPR?
Only in-hospital CPR. So you are making a decision, like we give aspirin for stroke. It's cost-effective. So for every stroke you prevent or every quality adjusted life year, I think it's like $300. Coumadin for stroke is actually cost saving. So what do you think is for in-hospital CPR, what is the quality adjusted life year? How much you have to spend to give you 1 quality adjusted life year for in-hospital CPR? $400,000. So it basically shows it's highly ineffective in terms of providing you any quality adjusted life year. So there's a nice paper. I took some of the slides out because of the time constraints, so I can show you. So CPR in ICU is not a good thing. It doesn't help. And these are all comers. These are 50,000 patients. So these are not just older people. These are younger people who have multi-organ failure, who are requiring vasopressor therapy and other stuff. So this is just to show you aggressive care during end of life among advanced cancer patients, because that's the talk today. This was a study by C.C. Earle from Harvard. He looked at patients with advanced cancer who died of breast, lung, colorectal, and GI malignancies, and he cut the cohort. He only wanted to study patients whose survival was less than equal to 1 year. He had pretty large sample size there, and what he showed that between 93 and 96, People are getting chemotherapy even towards the later part of their life. There was not major difference in inpatient days. The hospice, patient getting hospice prior to death went up, but the number of days spent in hospice was only 3 days. So pretty much most people were getting hospice towards the last stages of their life. And this is looking at the indicators. Person admitted to hospice, if they're admitted to hospice, they're less likely to get aggressive care. And this is just showing the distribution of a number of indicators of aggressive care. Chemotherapy use, ICU use, hospitalization. This is our paper that we were looking at ICU use and hospice and end of life for advanced lung cancer. Our hypothesis was that there is an increased diffusion of hospice. There's not good chemotherapy or treatment for advanced lung cancer. So as there is an increase in hospice use, we should see a decline in ICU use in these patients over the period of time. What we end up found that actually both are going up. People are getting both. So they are actually more people are getting ICU use, more people are getting hospice use. It turned out about 6.5% of patients were getting actually both. So they were actually, and it turns out clinically it did make sense because we see patient in the ICU, that's when we have this discussion, hey, let's go ahead, terminally wean this patient off the ventilator, and we transfer the care to Dr. Grumbles. So what we do is, here we got the patient already got an ICU, he already spent his 7, 8, 9 days there, not towards the last day he got transferred to hospice and the next day patient died. So the number of days spent in hospice, I think the median days was only 15 days in this study. Why is there overuse? So the question is, we're going to go back to Mac and I'm going to tell the story about Mac and the question is it patient and family preferences? Are we doing a lousy job or is it the patient and the family, they prefer aggressive care? Is it the physician preference? Or is it the religion that makes them harder to make those decisions, tough decisions? Is there a lack of trust in healthcare system? And there's a lot of data on healthcare disparity that talks about that. Is it inability to predict death with certainty? And healthcare delivery models, how are we providing healthcare this era compared to previous era has anything to do why we are having more aggressive care now than previous. This is basically a complex diagram showing that there are a multitude of factors that affect what kind of end-of-life care you are going to receive. It is not one factor, it is related to social issues, it is related to the delivery care model, it is available to the resources that you have in the area. Now, this was an interesting study, religion coping and use of life-sustaining therapies in end of life. This is a NIH-funded study. They actually looked at 345 patients with advanced cancer. Their median time to death was only 122 days, so they died fairly within the less than 6 months. And they were looking at intensive life-prolonging care, mechanical ventilation versus CPR in the last week of life. And it was fairly complex questionnaire where they ask you in a very detailed format, and I think there is the inclusion criteria that you have to have an advanced disease and you are able to speak English and have enough stamina that you are able to complete these questionnaire. And they were trying to ask you, do you feel like the God is punishing you for your sin? Okay, or do you feel like this is the way the life ought to be? There's actually a extensive amount of literature on religious coping towards end of life, and there's a positive coping and negative coping. Negative coping mean that this is your sin and you have to deal with it and you have to deal with all this punishment. So that is a negative religious coping, and it turned out people who actually have positive religious coping are high, they actually are more likely. Those who feel like that God is there to take care of them, they are more likely to receive mechanical ventilation, ICU, CPR. And it turns out, does faith make it harder to have a good death? And there's quite a bit of literature on that. And there's a nice cartoon I came across in our Chest magazine. He said, hey doc, if you are counting on a miracle from a God, why all the life support? Here's this patient, this wife's husband dying here, and she's talking, and she said, hey, my God needs all the help he can get. So you're looking for a miracle, but the God still needs all the help he can get. So there is some think about religious coping towards end of life and how it affects your end of life decision making. Now, how about prognostic disclosure to patient with cancer near end of life? This was a very well done study and very well publicized study by Elizabeth Lamont. She was actually, I think, at City of Hope in UCLA when this study was performed. She looked at 326 patients with cancer enrolled in 5 hospices in Chicago. So these are prospective studies. These are not resurrecting the dead. So these are people who were transferred to hospice for end of life care. And they asked the physician simple question: would you communicate the survival estimate? And communicate formulated and communicate different estimate than formulated. So you have a patient with advanced cancer. You're asking the physician, what do you think is the survival of this patient based on your clinical acumen? Is the patient going to live 60 days, 70 days, 90 days? And are you going to tell the same to the patient, or are you going to tell different than what your formulated survival is? So it turns out that this is basically the physician is telling the formulated whatever the physician think, and they're communicating the same. If you look at the dots above and below, they were trying to tell both above the formulated in most of these cases. And this was a very fascinating thing. The median actual survival for these patients were only 26 days. And the formulated survival by physician, they overestimated it, was 75 days. And they communicated 90 days. So physicians are overly optimistic, and whatever they think, they are even overly optimistic in communicating to their patients. Now, this is a fascinating thing. Stephen Jay Gould, have anybody heard about him? The median isn't the message. Okay, so all of the statisticians want to look at that. Here is the median, and we are drawing the line. So Stephen Jay Gould actually said, hey, you know what? Median isn't the message. He was an evolutionary biologist at Harvard. He was one of the smartest guy and got diagnosed with mesothelioma at age 40. Mesothelioma is cancer of lining of the pleura. And when he got it, he was a smart guy. He went to the library. He picked up all the books. He said, hey, you know what? God, I need to read about it, see what is going on. Then he said, you know what, I got nice buddies right across. They are smartest here at Harvard, so I'm going to go talk to them. So he went to doctor after doctor. They all said, hey, you know what, Stephen, I think your median survival is about 8 months at best with mesothelioma. So he got quite discouraged. He said, no, damn it, I'm 40. I don't think I trust you guys. So he went back. He pulled all the books. And he went from one trial to other trial to other trial. He lived 20 years. And he died in 2002 at age 60, cancer-free, but he had complications of some of the therapy that he received. If you get a chance, just type in Google, the median isn't the message. It is probably one of the best written pieces in terms of giving positive reinforcement when somebody looked at that. You know, at age 40, we're not talking about that. You know, we're talking about age 80 is very different. You know, then you can bring in all the statistics you want. At age 40, it's very different how people look at statistics with an N of 1. So I think this is a very good, and this is one of the reasons why people don't trust too much of us. So how about physician? We talk about, no, it's just an essay. It's just a 2-page essay. So then comes also, we talked about patients' beliefs. You know, we talked about religious coping. How about physicians? And this was very widely publicized study in Journal of Medical Ethics, and it actually went into CNBC, CNN, and ABC when this came out. This was over 9,000 physicians in UK. They asked them their religious belief and their end-of-life practices. It turns out the most religious physicians were less likely to discuss end-of-life care discussions or decision with patient, and they were less likely to administer narcotics and sedatives to their patient. So it's not only the patient's and family religion, it's the physician religion and belief also determine the end-of-life care that the patient is going to receive. So you can see that there is a lot of conflict going on when these end-of-life decision-making is done with patients. So here's another cartoon. Say, I admire your persistent doctor, but face it, you have lost this patient. So going back, like sometimes we are unrealistic. We are trying to give false hope, and we should be more realistic in what we think is going on. So what is the overall summary? So at the end of life, denial comes at a price, and here are some of the data to show. Now this was a study that was published in Archives looking at so they asked the question, have you and your doctor discussed any particular wishes you have about the care you want to receive if you were dying? So they asked this question to the patient who were dying of cancer. Have you just had a discussion? It doesn't have to be that you made a DNR of having just having a discussion alone with advanced cancer. And this was part of the multi-site coping with cancer study, part of the study which I showed you, the religion made an effect. Positive religious coping had an effect. Only about a third of the patient had end of life. Now these are another way you can look at it. These are cancer centers. These are center of excellence. So there may be some conflict of, if you talk to an oncologist, they will share that belief with you that, hey, if the patient is coming to me, I have to give some hope to the patient. So the idea is, an oncologist the right person in doing end-of-life discussion, or a geriatrician or a primary care physician the right person in having those discussions with the patient. So only a third of them had actually end-of-life discussion. And if you look at it, where they had an didn't have an end-of-life discussion, they were more likely to have an ICU stay, more likely to have a ventilator use, more likely to have death in the ICU. So basically, just having a discussion actually do help in appropriate end-of-life care. So this was the study that showed that, and also the cost was almost $1,000 difference in where they actually had an end-of-life discussion. That's why you saw that. And how did the Republicans took it? That, hey, they're going to kill the grandma. Okay, so the idea is that we are not having death panels. The idea is all having a discussion about end of life and paying physician for their time to have an end of life discussion. So this is the data behind some of those discussions that are going out at the Hill about end-of-life decision-making. So does cost really give you good care? So this is basically from the same study. What they showed that if you spend less, you actually had a better quality of death compared to if you spend more. These are the patients who are dying in the ICU. There's actually a nice scoring system of death score that how they calculate it. So spending more doesn't mean you get a higher quality of death. So in summary, patient with advanced cancer who reported having end-of-life conversation with physician had significantly lower healthcare cost in the final week of life. This was just looking at the last week. Higher cost was associated with worse quality of death. So this is similar to healthcare delivery model. So currently we have PCP who stays in the clinician or offices. Then we have hospitalists who take care of their patient. So now I would say Dr. Vogelpohl is here, and I respect him. He always comes, sees his patient who are admitted in the hospital. Even though it was a social visit, me and him share an 84 or 85-year-old lady. We took care of her husband. He was 92, had a stage 1 lung cancer, died of that. This other lady had bronchiectasis and have recurrent infection. And she also appeared on our JAMA video on outpatient to inpatient continuity. Her name is Betty. I forgot her last name. And so what happened now is, because with the fragmentation in care, you don't have the same PCP taking care of this patient when they're hospitalized. So you have hospitalists taking care of them, and there's a difference in healthcare delivery model, and nobody is discussing end-of-life decision-making or discussion with them. And they may have it in the clinic with their PCP, and now with electronic health record, it is still difficult to find where the code status is or advanced directive is hidden on that EPIC template. And we often have to deal with that. This was a study by Emmanuel, who was previous chief of staff's brother. He was the head of bioethics at NIH. He was promoting primary care, and basically what he showed that patient who visited more often their primary care physician in 6 months or a year prior to their death are less likely to be hospitalized, less likely to have ICU, and they are more likely to die out of hospital. And there are a lot more literature supporting that. And based on that, we have our own study where we looked at if your outpatient physician visited you during your last hospitalization. This was for advanced lung cancer patient. We shown that they actually had less ICU use. They were less likely to have an ICU use. The indirect inference from the study was that if your primary care is coming and seeing you, you're probably trusting that physician in making these end-of-life discussion and decision-making, and they're more likely to have appropriate decision-making. So now there is a little blur about palliative care in the hospitalized patient, and this is a study looking at 8 U.S. hospitals where actually they did pre and post, where they actually had a palliative care consultation model for all of these patients who were hospitalized with advanced condition. And they did a case control study with matching cohort. This was basically looking at, these are community hospital, academic hospital, so there were easy spread between community and academic hospital and fairly stable. And in terms of models, they actually have a RN, social worker, MD, different combination of palliative care specialist model. And what they showed was that when you have a palliative care consultation, so this is usual care. If you look at cost of care for a usual care, it continues to go up during the entire hospital stay. When you have a palliative care consultation at day 7, you see a significant decline in cost of care for these patients. And palliative care at day 10, you also see a decline there. Palliative care at day 15, decline there. So the idea behind there is whenever you introduce a palliative care, it actually reduces overall cost of care during hospitalization in these patients who have advanced. This is basically looking at direct and indirect costs. So basically the moment you have a hospice team, you stop ordering tests, then you focus more on palliation and control of symptoms. And hence, indirectly, it was first study showing true benefit of palliative care in these patients. And looking at price difference, you see that. And what they said was that, in 400-bed hospital with 500 palliative care consultation in a year, there's probably a significant net saving to the hospital to have that. I think Dr. Grumble's been successful that the hospital here has provided her, 4-bed inpatient hospice, and her services are tremendous for palliative care. Now here is the model for cancer or any life-limiting illness. It could be advanced COPD, advanced heart failure. The idea is, you offer them whatever the appropriate care is at the time of diagnosis and also introduce palliative care at the beginning. What is going on is most palliative care is right here, and it is actually very small. It's towards the end of terminal illness, and aggressive care continues to climb all the way towards end. So the model has to be bring palliative care up front in the beginning, and then you slow down the amount of aggressive care towards the terminal stages of these patients. And this was actually very nicely alluded to this study, which actually showed palliative care is better than any chemotherapy for advanced lung cancer. These were advanced lung cancer patients. They were given chemotherapy in both arms, and they were given chemotherapy and palliative care at the time of diagnosis of cancer. And it basically showed those who got palliative care with chemotherapy up front had almost 3 months longer survival, those who just got standard chemotherapy. And their depressive symptoms were less, and they were less likely to have aggressive end-of-life care. So this actually goes in favor that you have to bring in palliative care up front, going back that probably oncologists are not the right people in discussing end-of-life care at the same time talking about aggressive chemotherapy. So this was a study published in Harvard, got a lot of press about this thing. So now, does advanced directive work? So there's been a lot of this thing up and down. Advanced directive doesn't work. They change over time. We don't care about advanced directive. So this was the most recent study about advanced directive published in New England Journal. Basically, what they did was they looked at people who died, and this was actually a data from a retirement survey. So basically, these were longitudinal surveys of retirees over the period of time, and they also then look at those who died and those who actually had needed decision making and those who did not needed decision making, whether they have durable power of attorney or not. The bottom line for all this was if those who had a living will versus those who didn't, they were less likely to die in the hospital, they were less likely to get aggressive care, more likely to be focused on comfort care. So the idea behind this study was advanced directives do have benefit. The idea sometimes happen is we start having these discussions in the ICU, which usually is not a place at that time. You are clinging on to some hope, and here we are talking about death and dying. So I think the idea is to have these discussions in an outpatient clinics where the PCP actually put 30 to 45 minutes off their slot just discussing about advanced directives. So one of the new thing in the Patient Care Affordable Act is to pay PCP to have this discussion as a separate CPT code rather than just having a follow-up code. So now in summary, aggressive care during end of life is common. There's large variation in end of life care across US, and I showed you some data locally also. Patient and physician religious belief do play a role in end of life care. So there is something which is visible and something is invisible, and this is invisible in end-of-life decision-making sometimes. Current models are inaccurate in predicting survival. Continuity of care and end-of-life care planning can prevent unnecessary ER visit and ICUs, and early use of palliative care can curtail end-of-life care costs. So those are some of the things, and how will paying for advanced directive decision affect end-of-life care? It needs to be seen. I think those CPT codes are not out yet, and people have not gone back into that. So this is basically Ars Moriendi. This is how in circa 1450, this is how people used to die in 1450, basically surrounded by your family. This is a young child dying. And they used to actually have books written about art of dying during that era, talking about how you take care of your loved one as they were dying. Now, let me see. This is Ars Moriendi now, 2011. This is how Mac died in the ICU. And I spent an hour with Mac's wife just to ask her. And I said, hey, do you have any, did you talk about this when, he's 93-year-old? Yeah, whatever we could fix, we fixed. And is there anything else that you would want us differently? And she said, yeah, I talked to my primary care physician. We talked about we do not want aggressive care. And then I said, so he's in the ICU, he's in the hospital. And why did you bring him to the hospital? Why didn't you take care of him home? And her answer was, she said, I'm alone and I was very scared. And I couldn't take care of him. So the idea behind sometimes when you just look at these numbers of end-of-life thing, they do not tell the real story. Real story is she did whatever she could, and she did exactly what she told. He had a great PCP who's been taking care of him. They have the discussion. They have everything laid out. The idea here is because she was scared and she does not have any big social support that who could take care of him, and she herself was 80 plus years old at that time when he came in. So this is all I have, and I'll be happy to take any questions or comments. Thank you for your time.